Sure. Well, welcome everybody to our Affinity group for the Artificial Intelligence Precision Health Institute. And I'm John Shepard. I'm a professor at University of Hawaii Cancer Center. And I co-lead the AI PHI with Peter Sadowski, and Peter Washington is our host for our Affinity meetings. So I'm currently in Vienna, Austria at the moment. I'm not in Hawaii, and doing some consulting with the IAEA. So is that what you meant by an introduction, Peter?
I just meant you know Dr. Arasu, so maybe you could introduce him and then I'll give the
It's
rest.
true. I do know Vignesh. I wasn't prepared to do a bio introduction for you, Vignesh, but yes, I've known Vignesh for quite a while. He's a radiologist within the Kaiser Permanente system in Seattle, and is a well-respected leader in what's that?
Northern California.
Excuse me?
You said Seattle, or
I thought it was Seattle.
oh no, Northern California. Yeah, I stay in the Bay Area still.
All right, see, that's what happens when I do wing it. But anyway, he's been doing some great work and is one of the few radiologists that are really embracing and doing lots of good work with artificial intelligence. And we asked him to present the work that he recently published in radiology that compared several of the different algorithms available for breast cancer risk. So I'm going to leave it at that, Vignesh, and let you introduce yourself further. And Peter, do you want to introduce our group?
Sure, sounds good. Yeah, and I know my wife actually works at Kaiser, and I know there's a lot of differences between the regions, so it's a very important distinction. So we're very excited to welcome Dr. Arasu from Kaiser Permanente, and our broader AI PHI Affinity group, where we every month come together and hear from leaders in the field. We discuss various trends at the intersection of AI and healthcare, and we're pretty uniquely interdisciplinary, where we bring together people, of course, from computer science and engineering, but also from nutrition, radiology, genomics, together with non-scientists, clinicians, but also advocates, and all come together and hear from leaders in the field and brainstorm ways that we can bring the field forward. So we're very excited to continue that tradition today. Our overall goal is to foster collaborative interactions to solve problems that might have been unsolvable a decade ago and which are likely unsolvable now without this interdisciplinary collaboration that we're trying to foster here. So the format is a roughly 30 to 40-minute talk by a leader in the field, followed by an interactive Q&A session. So during the talk, think through the questions you want to ask our speaker, and we will have some time for that at the end. We have an exciting lineup of upcoming speakers in future months, so be sure to stay tuned. But if you have suggestions, definitely let me know and let John Shepard know and Peter Sadowski, and we could invite future people. The AI Precision Health Institute is part of the UH Cancer Center, as well as John Shepard's research lab. And we also collaborate closely with the Hawaii Data Science Institute. We have a paper of the month every month. So today's paper, or this month's paper of the month, is going to be the center of today's talk. So definitely recommend that you check out this paper for further details about today's talk. So without further ado, excited to have Dr. Vignesh Arasu. So Vignesh, take it away.
Great. Well, thanks for the inviting me to speak on our work and the introduction. And you can you see my slides and hear me, see me fine?
Yeah, we can see.
Great. Okay. Awesome. Well, yeah, no, thank you again. So yeah, my name is Vignesh. I'm both a radiologist and an epidemiologist. I practice in Northern California in the health system known as Kaiser Permanente. I don't have any relevant disclosures, though I will discuss independent research that we did on commercial products, but we don't have any, or I don't, and any of my collaborators have relationships directly with these companies, and by no means make any specific endorsements of the products that will describe. So for those of you who aren't familiar with Kaiser Permanente, we're the largest nonprofit health plan in the United States. So we serve about 13 million patients. This map shows you geographically where we're located, including Hawaii. And again, I'm based in Northern California. So 700 facilities. I mean, the scale of this is basically the same size as national health systems of like the NHS in the UK or other national health systems in Europe. In Northern California specifically, we have about 5 million patients. So the research I'll be presenting is based off data from those patients. We screen, there's about 700,000 women who are screening eligible. We screen about 400 to 500,000 women per year across 63 screening facilities. My clinical home is kind of in these areas circled here, which is kind of the Northeast Bay. And our research division is in Oakland, which is kind of the headquarters of all of Kaiser Permanente. Just something to know too is that we, unlike a lot of the US, screen predominantly biannually, so every 2 years. So, you know, my talk as a radiologist, I clinically do breast imaging, so I read mammograms, but also as a researcher, I'm evaluating algorithms in this space used for improving diagnosis and risk assessment. And so I want to just kind of step back with just sort of some of the principles here as I think about this problem. And really the benefit of when we do mammographic screening, so to orient you to this image, is that on the x-axis, each of these dashed lines represents the frequency of when a woman would come in for her screening. So let's say every 2 years or every year. And when a tumor develops at a very microscopic stage, as it passes through the y-axis of these different levels of starting from a very microscopic, undetectable level, at least with our current technology, to becoming localized, that we try to catch it at a time where we can detect it with screening so that we can prevent it from further growing and becoming regional or metastatic. And this is really what leads to the cancer-related morbidity and mortality. But in fact, the problem here is that unfortunately, not all cancers behave along these growth curves. We actually have a range of different growth curves. Some cancers grow so fast that we, with our current approaches, would not be able to catch them early enough to detect them before they become metastatic. And these are, again, a lot of the deaths. Whereas other cancers grow so slow, or to the point that it is almost a question of whether they actually benefit from screening. And in fact, if there may be some harm had we just never found these to begin with. And this is kind of expressed in this data kind of more granularly. So when we look at how cancer is distributed by stage indicates the higher the stage, the more likely it's regional or metastatic. There's a lot of subcategories within here. So about 80% of the cancers are early stage, and they represent only about 25% of the overall mortality. And essentially, with what we're trying to do in changing the status quo, for us to screen more frequently or do something more, there's really no further benefit, at least on the screening end. But it's among those who have more advanced stages that only represent 20% of the disease burden that actually represent the predominant number of those women who are dying from cancer. And here, some, not all, may benefit from earlier detection. And really, the goal of my talk is how we can leverage AI to kind of further decrease these gaps in care. Now, the gaps specifically are when we look at how these cancers are detected, these advanced cancers, stage 2A and above. About a third of them are detected by screening. And so that we're able to, some of these that are earlier stage, we may be able to intervene, but we may probably need to screen them more frequently. But specifically those cancers known as interval cancers that are missed, that occur between these intervals of screening, so between these dashed lines, in which we need to do something differently. And finally, those that are in a category, so that represents about a third of the women. And then the final category are those women who just are overdue, who don't present for screening in the bare minimum recommended guidelines of every 2 years. So these are the different categories that I feel are areas in which we can address using AI. So first, cancers that are missed during screening, that we try to find them earlier, cancers that grow too aggressively that we need to do something about them, and then these cancers that occur in women who are overdue for screening. So these are the three kind of broad areas of that I am exploring in my research and how we can leverage AI to address these gaps in care. And the amazing thing of what we've been able to do in computer vision AI. So of course, mammography has always been an area of interest in sort of the general area of machine learning. We've always had some level of quantitative imaging that we've used to apply to these problems. But it's really in recent time that we've had this acceleration of both in academic as well as in the commercial space of numerous algorithms that address these issues of trying to identify risk of cancer. And we've shown that this can now be accurate, efficient, scalable, and scalable to the terms of the size of Kaiser Permanente, and helping both diagnosis as well as future risk assessment. And in each of these different phases, the challenge of cancers that are missed at screening, I'll talk about how this can be addressed with computer-aided detection, cancers that grow too aggressively, how we can personalize screening, and then cancers in women who are overdue for screening using personalized outreach. These will all be different themes that I'll kind of address in the different projects that we're doing in my group. So starting off, just to orient the group of like, what is the workflow, I think is really important of where AI is actually intervening. So women broadly get screened, as I said, every 1 to 2 years. And if there's anything that's abnormal, it's read by a radiologist. If anything is abnormal, they're recalled in for additional imaging. So they do more focused diagnostic mammograms or ultrasound, and they see somebody like myself in a clinic. And if that's further abnormal, they come in for a biopsy, and then that's where we find cancer or we find no disease. In the situation where we're missing cancers at screening, so this is where we read a mammogram, we assess it as normal by a radiologist, and we expect that they'll come back in 2 years and be totally fine. But in actuality, about 10 to 20% of cancers occur where a woman then actually presents with a lump, and they come back, and a lot of times these end up being much more aggressive cancers. And so what happens oftentimes, so it's not that everybody can be improved for this level at computer-aided detection. There's still going to be cancers that just grow too fast, and that will be kind of the future sections of how we can identify those that are very fast growing and lethal. And on the flip side, those who are very slow growing, really, there's not really much benefit of AI. They're growing so slow that, if we miss them the first time, we'll catch them on the second or third time. But it's those who are in between that, ideally we would have caught this cancer in this blue line that has the potential for having a moderate risk of leading to a cancer-related death, where we may miss them on the first round or even the second round. And ultimately, it's really this gap here that we're trying to address with computer detection, where we're trying to pull this woman who ended up getting missed and getting found at a later stage to at an earlier stage, where we can actually avert kind of a potential harm of cancer. And so not all cancers here benefit from this. So about 75% of these interval cancers or these missed cancers are actually mammographically occult. And this is due to dense tissue masking, where the technology of the mammogram itself is limited. And this is where things like tomosynthesis or other supplementary imaging like MRI can make some inroads. Or there's just so kind of ill-defined that no human eye can pick this up. And so maybe there's some areas that a mammogram or an AI can help us assist, kind of augmenting in detecting these. But the vast majority of these, I would say, is not going to be solved with CAD, and these are for these other aspects that AI can serve. So about 25% of these interval cancers retrospectively were missed by a radiologist. So that is when they take a group of studies of these false negatives, these missed cancers. About 25% of them, the radiologists, a group of radiologists or experts may say, hey, this could actually have been seen, or this could have actually been seen on a prior mammogram. And there's a variety of reasons why radiologists miss them. So first, there's cognitive factors, again, things that are too small or too subtle, or you just may be tired one day. And there's a variety of different radiologists who read them. So there's a fellowship in breast imaging. I'm breast fellowship trained. So you may lack that sort of the training and the expertise, or you may just not have enough volume to really detect some of these cancers. And as a result, nationally, when we look at data, so this is a distribution showing radiologist performance in the U.S. From the BCSC, we see a wide range of performance, up to anywhere between 3-fold difference if you look at kind of the top 10 and the top 90th percentile versus the bottom 10th percentile for recalling and detecting cancer. And so this is the area that among those that were retrospectively missed by a radiologist, or that could be subtly found by AI, that we're trying to address in this sense with using CAD. So we started our approach by looking at a group of different commercial and academic algorithms that also serve the basis for the risk paper that I'll speak about subsequently. But this is really where we started off, looking at this at a CAD level. And what I want to say is that we need to address all these different areas holistically in order to address all these different gaps in care. So this is a retrospective study of patients who had mammograms in 2017. We looked at 2,000 some cases and 1,800 controls. So this is kind of a nested case control. And this compares the different AI algorithms here. And are you able to see my mouse, by the way, my mouse pointer? Yes, great. Okay. So the AI algorithms here all kind of aggregated around AUCs of 0.83 to 0.91. And again, this is a study, we started this in 2021. And as we'll see, or as we know, AI just kind of is always accelerating. So I'm sure that the performance of these algorithms will be even better. And again, to compare to what a radiologist performs at a very high level. So at least in my center, we kind of plot it. Usually radiologists, they don't perform at the extremes, really, they kind of cluster here. But if we were to fit a line here and compare the AUCs, so there's quite a bit of a gap here still between AI and where radiologists perform. But really the purpose here, and a whole separate discussion, is that I don't really ever believe that AI is going to replace a radiologist anytime soon. I think by the time that it replaces a radiologist is the time it replaces everybody and across every specialty and every kind of discipline. And that definitely may come or will come someday. But really my focus is how this can augment what we do as radiologists. And retrospectively, AI, when we set it at an operating threshold at which a human would perform, can find missed cancers, or these interval cancers, in about 25 to 50% as compared to the radiologist. So retrospectively, this would be assuming like we agree with anything AI flags. Obviously, there's downsides to that, but just starting off, like, where's the peak performance of how we can kind of close the gap of those cancers that were missed by a radiologist, or even just by mammography can AI pick up. So anywhere between 25 to 50% of how we operate. So now undertaking, starting a large comparative effectiveness randomized control trial. We've started doing some pilot work in about 25,000 women, but at the scale that we're at, we're targeting now starting trials beginning next year, where we can have multiple comparisons across multiple different AI algorithms. And that we can kind of leverage these outcomes pretty quickly, within a year or two, given our scale and how we're set up for kind of very quick cancer ascertainment. And recently, there was a group out of Sweden, the Masai trial was just recently published, that kind of give us some, I think, exciting potential perspectives or insights into where AI may improve upon cancer-related detection. So this was a non-inferior, or a safety analysis for their non-inferiority trial. Their planned accrual is 100,000. They had about 80,000 in this study. And this is comparing. I should kind of further detail this as they're double red there. We're single red here, single radiologist versus 2 radiologists. They're comparing an AI plus a single radiologist as compared to the control, which is 2 radiologists. And what they found is a 20% improvement in their overall cancer detection rate. Now, this isn't their primary outcome. That's their interval cancers, their missed cancers. So that'll take about another year or two from when they started this trial in 2021 before they're able to get this outcome. But already we can maybe get some insights into potential improvements in cancer detection from AI alone. Just for the kind of the time, there's a lot of potential downsides and why this is not at all a perfect measure of interval cancer, right? There may be a lot of overdiagnosis, there may be a lot of prevalent cancers here, but at least giving us some early evidence of where AI may improve. And the very important point here is that there's not actually been really a significant increase in the false positive rate, which is actually the more surprising of these findings. Before, we've had multiple other algorithms, a decade ago, where we've had FDA-approved algorithms that help with cancer data detection that showed that although there was improvements in cancer detection, there was a huge increase in false positives. So really some really surprising results here. So now I want to move on to kind of the bulk of my talk, which is about understanding risk, future risk. So most women who develop breast cancer have no identifiable risk factors using traditional risk. So that is using family history, the known genetic mutations that we have, a prior history of breast cancer. If you put all these different known risk factors, which we've known for decades, we really haven't changed kind of, and including breast density in here, the number of women who meet these risks that have an identifiable risk factor. So depending on how you want to kind of slice and dice it, maybe approximately about a third to 35% of women have a known identifiable risk factor. And so in Kaiser Permanente, most women appear as average risk. And so really we have a one-size-fits-all approach. And unfortunately, we miss a lot of those patients who have these very fast-growing cancers because we can't identify their risk. The majority of women have no underlying risk factors. And as we screen women here, and as is recommended by the USPSTF, most women screen every 2 years. We actually give women the option to screen every 1 to 2 years, but we only remind them every 2 years. And there's not any kind of a consistent approach to using kind of even the existing risk models for shared decision-making because it's systems are not set up or it just takes too much time in like a 6-minute primary care visit. And so this is, I think, the story for most women is that there really isn't kind of individual level risk assessment. And moreover, that when we do that, most women, we can't identify risk factors who develop breast cancer. And the 20% who do have identified risk factor, this is a little bit of a smaller number because before I was trying to be as liberal with if we use every possible known risk factor that's known. But practically speaking, not every woman gets risk assessment and not every risk factor is taken into consideration because of the time and cost. But of those in Kaiser Permanente, 20% are considered above average risk and they're screened every year, or if they're very high risk, they have BRCA, like a BRCA mutation, we screen like every 6 months. We really are based off kind of an opportunistic screening of trying to identify these risk factors. And as I said, really there's not a consistent way of risk assessment, and our risk models currently are very limited at identifying at all risks. So this leads me into the paper in which we compared these different algorithms that we started looking at in the CAD setting at understanding kind of 5-year future risk prediction. So this is a little bit of a different study population. So this is a nested and designed, this is a nested case cohort study among women in 2016. So we took kind of that whole batch of women. And furthermore, we looked among women who had a negative screening mammogram at final assessment. That is, we did whether they were read negatively at the time of screening or they went on to diagnostic and it was negative, or they even went and had a benign biopsy. We just took that cohort of women, took their screening mammogram in which they had no obvious visible evidence of cancer. And so we had a population of about 350,000 women. We excluded women who had very clear high-risk features like prior history of cancer or genetic mutation. And then we did a nested case sub-cohort. So we had a random sample of those women, so about 13,000 women. And how kind of a case cohort design works. So it sort of gives you both advantages of a cohort design as well as a case control design. So you sample your underlying sub-cohort, so you have some cancers actually in your denominator to give you kind of the population-based underlying incidence. And then you sample all the cancers. So we had about 4,000 some cancers. And that is really what gives you the power here is the number of cancers. And we looked at 2 open source algorithms. So an algorithm developed at NYU and the MRI algorithm developed at MIT and MGH, and compared them also to commercial algorithms, Mammascreen, a company called Therapixel in France, Chiron, a UK-based company, and Profound, which is an ICAD, which is both a US and Swedish kind of company. And compare this to the BCSE clinical risk model, which is kind of what we thought of as our standard of care. And so each of these algorithms, the majority of them were made for computer-aided detection, and they were therefore trained on short time horizons. So showing all these different algorithms, including the BCSC, which was trained on cases over a 5-year period. So we were interested in just understanding, how does risk prediction work when you compare it to an algorithm like MRI that was trained on cases over 5 years to these that had various levels of time horizons, 2 years as little as 3 months. And our outcome was cancer over this 5-year period, and using the metric of time varying AUC, which is a little bit different than like the standard AUC approach, and at least among statistical community considered to be kind of an improvement across the C index, and giving kind of a direct interpretation of what we look for, and also taking into account the dynamic definitions for time to event outcomes. We also, as I kind of explained in the paper, kind of use additional approaches for how we kind of account for censoring, as well as our sampling distribution with weights for case cohort sampling. All right, so I'll kind of take you through kind of this really busy table, kind of stepwise here. So in our first sense, we looked at kind of interval cancer risk. Those cancers, here we're defining interval cancer risk in the first year. Looking at cancer the AUC, time varying AUC, confidence intervals, and the p-value comparing to the BCSC. So our performance here showed a significant improvement above and beyond. So AUCs ranging between 0.67 and 0.71 as compared to where clinical risk models perform. So again, just using the image alone, how AI can performs already better for interval cancer risk as compared to clinical risk models like the BCSC, which all pretty much operate on the low end around 0.6. And then comparing this both for 1 year as well as kind of cumulative risk across 5 years. So the AUCs kind of maybe dip a little bit, and there's more sort of differences as we'd expect, those that weren't trained for as long a time horizon, like these on the lower end of the lower rows as compared to like the MRI algorithm. But overall, all significantly different and better, again, just using the image alone as compared to the BCSC algorithm. And so part of the, sorry, just a time check. So are these, how long do I have till? Because I'm already at the half-hour mark here. I just want to make sure I kind of pace myself appropriately.
We have till the end of the hour, and we could split it however you want.
Okay, so maybe should I talk maybe 15 minutes? Is that okay? And then okay, great. Yeah. And sorry, I'm already talking really fast. I always put way too much content in here. But really, how much of AI is predicting future risk versus how much of that is just CAD risk? And so you can look at the Kaplan-Meier curves and really see that if you're predicted as high risk early on, your risk continues to stay, i.e., the deciles of risk continue to stay separate on pretty much across the whole spectrum. So if you're low risk, you stay low risk early or late, really telling us that this information is both informative, both for early detection as well as for future risk prediction. The largest change is really in the first 2 years, and this is really as a result of finding, like being screened again and finding kind of new cancers, but really the case remains. And to further kind of understand this, if you just look at cancers, the AUCs, just at incident AUC from 3 to 4 years or 4 to 5 years, which really doesn't have any clinical relevance. It's like saying, can I predict your risk at year 3, or can I predict your risk at year 4, rather than the cumulative risk over 5 years or over 1 year or over 10 years. But just to suffice to say, it helps us understand the relationship of how AI can perform, and really something like MRI continuing to show robust performance out to 4 years and maybe dropping as you get to 5 years, whereas the other algorithms really starting to drop off and being more comparable to the BCSC. But overall, again, a really, I think, interesting and novel finding of that, hey, algorithms that were trained just for a really short-term time horizon, there's something that we're still extracting, whether it's density information, whether it's other aspects that really give us information easily, conveniently on a data element that's universally acquired across this group of women who were most concerned about making decisions for screening, that we really have been able to do above and beyond a clinical risk model. Now, of course, the further thing is, okay, this clinical information is available and we shouldn't waste this. So how can we move beyond these performance of just AI versus the BCSC, but really combining clinical risk information with AI. So we did this as well. We made a Cox model where we combine these just really in a very simple way, just combining them with restricted cubic splines, just a vanilla approach. And of course, there's many ways to combine data. And we're showing kind of cross-validated estimates here. And now I'm going to show you here the improvement of adding BCSC with AI in purple as compared to just AI alone. And what we found is that the increase was very incremental. But as we looked at over 5 years, that tended to kind of narrow the differences across the different algorithms. So algorithms that before were trained on very short time horizons and performed worse just alone with AI alone, when you add clinical risk information, really kind of helps lift all ships and make them more kind of consistently in the same area. So, in conclusion of all this is that, really we see this as AI really kind of giving us a very consistent way that we can do population-wide risk assessment. And when we finally, maybe one other thing to add in here is we also looked at calibration, which is really important for risk model evaluation. You can't just use things out of the box, and Mirai, for example, was calibrated both for the diagnostic setting as well as future risk. But really some simple recalibration could allow, whereas the BCSC was well calibrated in our population, that these algorithms can be recalibrated and refit so that it's valid for using for future risk prediction. So, just to kind of like to conclude on all this, so, we really have no efficient way to identify risk factors that are known, and moreover, when we have those, they don't really address the whole population. So the final thing that we didn't really include in this paper, but is kind of the next step of sort of this thing is how much of that risk is attributable to AI, or how much of this can we improve upon finding new risk factors that didn't exist before. So if we look at women who are identified as above average risk, this, going back to this Kaplan-Meier curve, this equates to having a 5-year risk of about 2.4% in the population. And when you look at how many what proportion of cancers were identified, if you look at just at AI alone, this was about somewhere around like 40 to 50%, depending on how you slice and dice the data. But really the kind of the concluding kind of story here that is not yet in this paper, but is kind of the focus of my future work is like, how much of this can we actually improve upon identifying risk factors for women who go on to develop breast cancer? And in that earlier slide, I said using those known risk factors, again, family history, personal history of breast cancer, genetic mutation, atypia information, other information, even density information, it's really hard to really budge that where most women have no identifiable risk factors. And when you add AI, although there is some overlap, there is a lot of independent information. So we're estimating up to 75% of women who develop breast cancer can now have identifiable risk factors using AI. There's a lot of ways that would further nuance this, but really to me, the take-home message of this is that AI can really demonstrate measurable improvements of identifying risk factors where we had none before. All right, so there's a lot of other future areas that we're moving towards. So understanding underlying bias, looking at longitudinal change repeatability. We're developing models that also combine genetic information, SNP data. So part of what is great about working here is that we have these amazingly huge kind of unparalleled cohorts. So we have this large cohort of over 100,000 women who all have both imaging data as well as full genetic data. With 8,000 cancers and 15 years of follow-ups that we're using to develop, we hope, the next generation of kind of a breast cancer risk prediction. And so we have an ongoing RL1 project with collaborators at Mount Sinai and MD Anderson, in which we're kind of building this data set as well as the risk model. As well as we're applying with the Wisdom team with a lot of the UC, University of California hospitals and others nationally to actually implement this into a trial and furthermore predict aggressive versus non-aggressive disease. So really a lot of, I think, work though, which I'm leading in this area across these different grants to develop this next generation model where I really feel like AI is a centerpiece for this. And where we hope to move forward, going back to this whole image of, okay, we have this range of different tumor biologies, and we really are doing a one-size-fits-all for the majority of women where we can't find a risk factor. How can we now identify those women who are at very high risk for very fast-growing lethal cancers, where we can start doing more frequent screening or supplementary screening so we can identify them at an earlier stage? And on the flip side, potentially finding those who are very slow risk and where we can really fine-tune and perhaps kind of extend out how often they need to get screened, or other ways that we can really match the way we screen to their actual risk, which we really haven't done at this point. Okay, so just in the last few minutes, I'll just conclude with the last aspect, which is outreach. And historically, about 10% of women are overdue for screening. And as I said, about a third of them contribute to the mortality related to breast cancer. And this is really a metric that's used as a quality measure for health systems that really contributes to the reimbursements we get from Center for Medicare Services, so for Medicare. These women have a much higher risk. 1 in 3 of these advanced breast cancers, as I showed, occurred in these women and contribute again to the majority of women who die from breast cancer. And especially during COVID, we had up to 4 times as many women who became overdue because of these delays. And we're still playing catch up in our system, and I'm sure in many other systems, because of these now tidal waves of demand, where shelter in place really kind of mucked up how women come in for screening. And how this is kind of displayed is, so in any given year, historically, we may have kind of a very steady state of women who come in for screening and kind of a certain limit of screening capacity. So women can always come in for their appointments, but now because of COVID, a lot of women waited and then a lot of women came back. And so we kind of have these now really kind of cyclical, like tsunami waves of demand where all these women kind of want to come in for screening, and then because of limits of capacity, then they have to wait for their next appointment, and just really this problem cascades and compounds. And so before, again, we had no effective way of knowing who, well, one strategy would be, okay, first kind of trying to bring in women earlier, but who to bring in earlier. And this is, again, where risk information is really essential, is so knowing who would be at high risk and bringing them in earlier could really help kind of not only solve our volume issues, but also help try to bring about women who kind of can benefit from earlier detection. And so we went about evaluating their risk using MRI, so across a whole range of women. So we had about 500,000 women in which we generated their risk information using MRI and the CSE risk score, and using this both for understanding who's at risk, but also inviting those women who are at higher risk, who I'm kind of representing here. This is still hypothetical data. We're now looking at our outcomes in dark blue versus those who are at low risk in white, and really bringing those women in who are at highest risk earlier, as well as kind of really flattening out our demand curves. So this is kind of the focus of work that we've done for the last couple of years, and are now actually looking at the outcomes, but just some early evidence to show that the same kind of retrospective work is of showing kind of the amount of risk information or women who develop breast cancer. We're showing kind of prospectively, we believe in this data, but really just kind of still working through that as we speak. Okay, so let me just kind of conclude and pull all this back together. And so, where I see how care will evolve and what I'm trying to build in Kaiser Permanente is every woman who has a mammogram should be evaluated with AI. And in the kind of at the point of care, if there's something abnormal that it's being applied in CAD, and that really helps downstream find cancers earlier that were missed. But among those women who are quote unquote normal, that we use that risk information for their future risk to understand where we didn't know, but now can say that for the vast majority of women can understand their individual level risk and really personalize their risk for how often they need to come in, whether they need to come in frequently or need to get supplementary screening, and really titrate that based off their level of risk. And also when anything causes them to be overdue for their screening, that we really are able to personalize how we outreach them, particularly in these kind of catastrophic events like COVID that really led to delays in diagnosis. I want to first acknowledge this is a huge group of people. We're a huge organization, a huge group of people. So, this is really multidisciplinary research. So starting from just stakeholders and leadership, the fabulous research team that I help lead and work with my clinical colleagues. And this is not just in Northern California, but across the different regions of Kaiser Northern California. Really a strong collaboration with IT to actually make this implementable, and a bunch of both internal and external funding. The last thing I just want to put a plug in is that for those of you who are thinking about postdoctoral fellowships, we have a range of 1 to 2 year fellowships in the Division of Research at Kaiser Permanente. I hope I've shown you kind of really the amazing kind of research you can do with both the unparalleled data as well as really a direct pipeline in understanding how this impacts clinical care and actually implementing things. So really my focus is translational work, how we can accelerate, these kind of amazing innovations into practice. And so I hope to start taking on postdoc fellows, but also there's just a number of amazing leaders in our organization, and there's a link here for you to look for any interest in postdoc fellowships. All right, so let me just kind of stop my talk there. Sorry, that was maybe a little bit drinking from a fire hose, but would love to connect, and this is my email if you have any further questions. But let me stop this talk here.
All right, thank you so much. That was great. So now we'll take some questions. So any questions from the audience? I could start with one while we wait. So for the discrepancy between the clinical performance for screening and AI models, how much of that do you think might be attributable to, I guess, what the biology community calls batch effects, where the model's trained on one type of, clinicians write on the mammograms in one way at one place versus another, and like there's slight different variations that could really degrade the performance when you try to use it on external validations at like Kaiser's. So how much of it do you think could be attributable to that versus the AI itself?
And just so I understand, so in the CAD sense, is that what you're asking? In this kind of figure here? Yeah. And then again, you're asking how is training on what type of data? Like just being reliant on human performance kind of data of like, okay, these were predominantly cancers detected by humans, and using that as your predominant training data. Is that what you mean? Or
well, so like the training data might just have different noise from when it's collected at, say, NYU versus these other places where you're getting your external validation data, like you're getting those models were trained with data coming from a certain source, and those data have certain qualities about them that are just specific to that place of data collection. And so if you train an AI model on those data and then try to apply it externally, you might expect a degradation of performance. But so I mean, how
like a brittleness kind of question of so I would say that there's a couple of things. I think first, there's just, when you look at AUC specifically, there's just underlying differences of cancer incidence that affect your AUC. And so like what may be your baseline AUC when you compare is not apples to apples in that sense. Like different, comparing Sweden to the US is totally different cancer incidences. But then further still, on the training data of like, if this answers your question, like, if it's equipment differences or, just kind of post-processing of the image differences, and just like how generalizable or brittle is it when you bring it across, across the country to like, to my center. We looked at that. We have both, for example, Hologic and GE machines. So we were able to look at like equipment level differences. And we found, at least like the Mirai algorithm, or actually all the algorithms, we look more at the future risk, but I think this will generalize to the CAD sense to be actually fairly robust in terms of equipment level differences. But even there's small differences that we found regionally, like we were doing some of this in Southern California as well. And I don't know how much of that is, I would say it's not so big a difference that it's like, it shows like an AUC difference of maybe 0.01 or 0.02, which could be attributed to just underlying differences in cancer incidence. But I think it's really hard to understand how much of that is really due to that versus just like the underlying training approach. And so I think does that answer your question?
Yeah, I guess part of the discrepancy might come from, is there a difference between the performance reported in those original papers and what you found when you validated?
So maybe one question about this is the Mirai algorithm that I get asked a lot, is that the Mirai algorithm, their published numbers are way higher than what we found. And so first, to like kind of address that, they had an AUC of like 0.7 or 0.8. That was because they mixed both diagnostic CAD as well as future risk. So that may be one thing off the bat to address, of like what seems like an apparent huge difference. They have some other tables where they actually look at just those who had future risk of cancer, and that was more similar. But that is just to kind of address that maybe one area where there may be a huge difference. Otherwise, it seemed fairly similar. I mean, we had maybe on the lower end when we spoke to our commercial partners, maybe a slightly lower score than what they were expecting. And I think that's a combination of just differences of both our patients and the machines and the soft and the the way our images are post processed. So yeah, I think I think that's but I felt overall we were consistent, allowing for those small differences. There weren't huge differences.
Okay, thanks.
Sure.
Any other questions? John?
Vignesh, I was thinking when you were presenting the risk by year, and it reminded me of a study that was done in osteoporosis for heel ultrasound that showed that how many years in advance would heel ultrasound predict fracture risk. Mm-hmm. And it showed that after about 5 years, even though heel ultrasound was just as predictive as DEXA of the hip for predicting hip fractures, in like a mixed group of where the fractures could have happened over any time over 5 years. The heel ultrasound just really didn't predict fracture risk after about 5 years.
Yeah,
and while bone density predicts it out to 10 years or more. Mm-hmm. So the same thing's true with breast density, and that breast density has been shown to predict out 10 years. Mm-hmm. And I'm wondering, so some of what you're saying about this attenuation could be is exposure to late occurring or cancers that are occurring far away from the when the film was collected, and it just needs to see some unique signal there. But could it be that really the AI is picking up on some structural things that are predictive early on, while when it predicts later, it's really using maybe the more of a breast density signal?
Yeah.
And I'm wondering if you could think about how you could tease those apart to show that the later risk of AI prediction might be exclusively breast density, while the early risk might be breast density plus combined with the textural information that it's picking up on.
Right. Yeah, I think this is a really fundamental thing, and in some ways, I'd love to hear too, like where the field is with explainability of models, because this is just I think more your guys' area. But I mean, what I was trying to address here with that question is BCSD, for example, includes breast density, although obviously in a very rudimentary way, maybe versus like a more quantitative measurement. Where we're just using the radiologist, extremely dense or heterogeneously dense, the 4 categories. And in that, when we combined it, like for example, showing you here, the added benefit, you could say, of where I guess you'd have to do a model where you have just breast density alone without which we could do here, versus just like an AI model. But I honestly, I don't have a better answer here. I'd have to think about that. And if you have any suggestions, I'd be open to it, of how you kind of disentangle that, because I do believe there's a lot of overlapping here. There's also probably a lot of overlapping things that would predict for age or race, ethnicity, or all the other kind of factors that that we think of as maybe not something that an image should be able to see, but there's studies that have been shown that images can predict race, ethnicity. So I think there is some level. I don't know how to tease apart what proportion of it is that, and I think that just gets to like an explainability of the model that I don't know how you get at that. But I do think there's a lot of independent information above and beyond that that we're seeing. I don't know if you had your thoughts on that.
Well, it might just mean that you need to have more of an to accomplish it. You might need more of an explainable design in the modeling, so that you have these intermediate defined features that you can look at how those attribute to overall risk at each progress each year.
Right.
So that might get to it. What's that?
Yeah, to that, the ICAD model has more explainable features. So that actually gives you like calcification information or like symmetry information or other kind of more, kind of human defined features. And that, they found, I think, additional information like from the calcification patterns that I think, that, there's probably some correlation with density too, but I think shows, kind of some independent information above and beyond what we think of as like, what else is there that it might be seeing. But I do think just across the whole field of computer vision, there must be some higher order thing that is not, human engineerable, even whatever second, third order things that maybe, I don't know, that's just kind of my more uninformed opinion. I know this is your area of expertise, but it just sort of feels like that's kind of where it seems that there's a lot of kind of that may remain unexplainable kind of information that's sort of this higher order level of abstraction that is independent and above and beyond what can be engineered or designed.
We have a lot of people on the call, and this is a great opportunity for anyone to ask any questions. Please just raise your hand, and so we can see you if you don't want to just blurt out. But please ask any questions you like. Ariana.
I'll ask a question. Thanks for a great talk. With the AI risk models, do you anticipate or have you seen any differences to clinical care resulting from using AI risk models versus like the BCSC where they're completely interpretable? Can you speak to that a little bit?
Yeah, not yet. We're not quite yet at looking at prospective impacts. That's where, so first I think our CAD trial will really show, impacts of kind of, which is really short-term risk, like understanding detection. But the future risk, that is something that we hope to see some data with the outreach information. So far, what we're seeing is that basically it remains true that this is data looked at retrospectively. We're going to start looking at it where we prospectively used it, but it really comes down to how you use that and intervene. And so we're not yet at the point where we can tell a patient, hey, this is your individual risk. We're at that, or we're getting to that point, but up to this point, it wasn't something that we felt confident enough to say, not only do you have like X, Y, and Z, or maybe you had no known history, but hey, you now have this history. And it's this very abstract thing of AI. Now, we always had precedent of that with breast density, where women would get these letters in the mail letting them know about having high risk density. So they have some, at least thankfully, some, it's not like they haven't felt that before of like the image telling them this is their risk, but really now kind of being much more implementable. I think we're at that point. So we're just now kind of cracking that and starting understanding how we could look at that in kind of personalized risk-based screening approaches, like in the wisdom trial or in other forms of outreach. But really just communicating that risk, is like the first step. And that's something that we're just now working through. But there's so many dimensions to that, like understanding who wants to know the risk, who doesn't, how you communicate that with, literacy rates and so there's a whole health education aspect to that. But that's all kind of aspects that I'm diving into.
There was a question in the chat about how medical students could be a part of such a great research. And maybe I know that you got involved in AI research during your residency or during medical school at UCSF, right?
Yeah. I mean, at that time at UCSF, it was really just quantitative, not, it's machine learning, but it was not really AI at that point. I mean, I really only started getting into AI while I was at Kaiser Permanente.
Can you give a little bit of story about how that occurred? And
yeah, sure. I mean, with AI specifically, or
sure, just your route into AI.
yeah. I mean, it really was. I was doing a lot of work, not in mammograms, but really MRI. So I did a lot of work with Noah Hilton's lab on using MRI for predicting response to therapy. And then, when I joined Kaiser Permanente, it's a large integrated managed care system. We don't do the sexy, like, high-end MRI stuff where we really have all these different trials going on. And really the problem that I was confronting is, like, really how do you address the community-based practice, which represents most of the US healthcare, and that's really using mammograms. And so I was trying to figure out how can I really kind of find a way to utilize information. And just at the same time is when all this stuff started emerging with algorithms like Mirai, where you could use something off the shelf, all these commercial algorithms. And then really at the same time having this kind of IT-led kind of initiative that really were interested in how we deploy AI at scale. So that's kind of my story. I would say, like, I'm really just kind of we're just really getting started, and how, starting to take on postdocs. I'm not yet, I get approached by med students. I'm not yet at the bandwidth capacity yet, though I'd love to be able to help, all researchers of all stages in this. But I think there's more and more labs that are becoming involved. I think at some point, though, I will offer kind of research rotations, which we have at the Division of Research. So that may be one way to have some, like, dedicated time. But yeah, hopefully soon. But for the specific question of medical students, not anything quite yet. But hopefully soon. But please keep in touch and send me your CV, for example. Yeah, and just like the last point about public databases, I know there is just more and more, like, mammogram databases that are being released. We're not yet doing that, but I know, like, Emory has done that. I know there was a review paper recently about public databases. I'm sure the NIH has an image repository of mammograms, but I know there's a recent review that had, like, a great description of all the data sets that are available for machine learning.
Okay, well, Peter, we're at the top of the hour.
Yeah, let's give Vignesh another round of applause for an excellent talk. And thank you so much, Vignesh, for taking the time, and looking forward to keeping in touch.
Great.
Have a great week.
Well, thanks, guys. Take care.
Okay, thank you again.